Assalamu alaikum, sir. I'm hearable.
Salam.
Yes,
Yes,
sir. Uh, okay, sir. Sir, this is a chest X-ray frontal projection of an adult patient. I see multiple chest leads are seen to be placed. Most likely, it is an ICU or portable X-ray. Sir, I can appreciate there is a area of void, vessel void is noted in the left hemothorax. I'm suspecting pneumothorax on the left side, and also
don't
there's a
worry.
mild
This
pleural
this projectional, this projection. What
projection.
else?
Okay, sir.
What
And
else?
sir, there's a mild pleural effusion is also noted on the right side. Maybe it's
Excellent.
positional. And
Excellent.
sir, there is so no air lucency in the neck region. So I'm not suspecting pneumothorax. Only my left side in pleural effusion. So cardiac
What is?
size, I can't come.
Mm,
Sir, elevated right diaphragm, but it's still portable supine. Sorry. Uh,
mm-hmm.
Other trachea seen in place, sir. And sir, some air bronchogram I can appreciate on the
Mm,
left side.
yes.
And sir, some consolidative changes on the left upper zone. Sir, any history of any foreign density or any in the
Oh,
ingestion?
you didn't give me a chance at the beginning to tell your history, so I keep silent. This
Okay, sorry,
patient,
sir. Yes.
this patient. Piece of advice: if the examiner didn't give you a history, no, ask him. What is the history?
Okay, sir.
It will help you
Yes,
so
yes.
much.
Okay, sir.
This is a case of trauma.
Trauma. Okay, sir. Okay,
See?
sir.
What is your
Okay.
next step?
Sir,
I think now your mind completely changed.
yes, sir. Yes, sir.
Mm-hmm. Tell me.
Okay, sir. So in this chest X-ray, I don't find any rib fracture in these provided images, but there's a mild pleural
Yes,
effusion on the right side, and
yes.
I also want to and the cube view to confirm that there may be some occult pneumothorax, if possible.
Till now, this is a
Okay.
trauma patient.
Yes,
Do you
trauma
want,
patient.
يعني,
Yes.
to ask if for anything else?
Uh, okay, so trauma patient. Sir,
What is your next
I'm just
step?
looking.
What is your
Then
next step?
next step should be, sir, if there is a chest complaint, shortness of breath, I would go for chest CT scan if it's
Yes,
a patient is
yes. So,
complaining.
so, so you should, after describing, you squeeze the case, the X-ray, and this
Yes,
is
sir.
the maximum finding. So you should ask
Yes, sir.
for CT.
CT.
Go on
Okay, sir. Sir, may I
and
ask
scroll.
control? Yes,
Yes,
yes.
yes.
Okay, sir.
Take care, my
Uh,
colleagues. This is minor
yes.
technique problem will not help
Okay,
you
sir.
inside the exam. Why? Because if you
Okay.
didn't ask, the examiner either will not give you, okay, or he will
Yes,
be
sir.
angry. I remember in
Yes.
one case I didn't ask for the
Yes.
next, and I complete it was X-ray, and I
Yes.
completely lost the case. Okay,
Okay. Yes, sir. History should be asked.
on.
So, sir, I'm scrolling from top to bottom chest X-ray. It's a contrast image, axial images. So I can
Yes,
appreciate, sir, it is a dense fluid noted on the right side. It's likely
yes,
hemopleural effusion and with
excellent.
underlying lung collapse. Sir, I'm trying to find the cause for this effusion.
Yes,
Uh, Again, I want to check the chest images. So I didn't find any extravasation of contrast
are you
through the
sure?
arteries.
Are you sure? Look again.
This is azygous. Okay, sir, sir. There is some peripheral base hyperdensity is noted.
Yes.
On the along the right posterior chest wall, there is some hyperdensity. Is not due to rib fracture, but there's a some leakage or some extravasation of contrast into the uh, right lower zone.
Okay.
So
So,
until so there is an vascular injury due to trauma.
okay,
Maybe
excellent.
shear forces may lead to this vascular injury and leads to hemopleural effusion.
Okay, what's your next step, doctor? Tell me.
Uh, okay, sir. So next step should be drainage of this fluid and this cytology and DR of this fluid as well, and also urgent referral to the interventionals and to the physician about this active leakage of contrast and for appropriate management for this leakage of uh, vascular
In
embolization
your
of this fluid.
in in your normal practice, you will do
Yes,
first.
sir.
What will you do first?
Sir,
What will you do?
I should inform the referring physician about the this active bleed
Hmm. No, you will do drainage first, or you will refer
drainage.
to intervene, or you will or you will transfer to interventional radiologist.
Sir, if a patient come to us, then we have to drain the fluid. That's decompression could be released from the patient. But due to this
Mhm.
active bleed, I'm more concerned for the active
Mm.
bleed of this patient.
So tell me clearly, what is your
Okay.
next step? What is
Sir,
your
I
next
think
step?
I
Mm.
Okay, sir. I think I should drain the patient first and then send. If patient is stabilized, I will check the GCS and of the patient condition. If patient is stabilized, then pleural effusion should be drained, and then in the counterpart, we should inform on the board about the active bleed.
Thank you, doctor, so much. But the management is not, not correct. Why? This is
Okay.
hyperdense pleural effusion. Okay.
Yes.
Then there are few leakage here. This one.
Yes.
Okay. This one here. So next step is angio. Why?
Engine.
This pleural effusion cause a tamponade and decompressing
Mm.
the bladder. If you drain first,
Ah,
this artery will bleed more and more. And you see, that is why here, next step was this one, angio, occlusion. Okay, very
bronchial
critical,
engine.
very critical sequence of management. Why? The patient may die. Thank you,
Yes.
doctor, so much.
Thank
Next candidate.
Good evening. Assalamu alaikum.
Wassalam, good evening. This patient is a 35-year-old male patient complaining with presented with chronic ankle pain.
I have been presented with a radiograph, a lateral view for the left ankle joint for an adult patient complaining from chronic ankle pain. In my first inspection, I cannot see any obvious abnormality, so I will go through my checklist. I cannot see any fracture line within the both tibia, distal left tibial or left fibular bone. I can see that there is no evidence of fracture or even stress fracture within the calcaneus bone. There is no evidence of coagulation seen between the metatarsal bone, and I can see that the rest of the metatarsal bone appears grossly normal. In my routine practice, I will ask for the other view for this patient.
Doctor, are you sure there are no coalition?
First, I want to see if there is anterior talar beak. I can see now after zooming the image that there is anterior talar beak is noted. After reviewing the area between the calcaneus and the talus, I suspected that there is evidence of C-shaped coagulation, which could represent bony coagulation between the calcaneus and the talus, representing the C sign. However, I want to see if there is any other view to confirm. I will go for CT scan axial images.
Which view, which X-ray view will confirm you the tail of calcaneal coalition?
Oblique view can be helpful.
Are you sure? There are a better view.
Maybe
Can you
the
believe?
yes AB view, maybe not the lateral.
Not AB. What about the axial?
Axial view, yes, yes, yes. Sorry.
Yeah, axial not working. Axial is very very important in confirming tail calcaneal coalition. Uh, this is a CT.
Yes, here I can see that there is this is uh, coronal images for the left ankle for the same patient, and I can see that there is bony projection noted between the calcaneus and the talus bone on the medial aspect, representing fibrous, bony coalition, talocalcaneal coalition. In my routine practice, I will also ask for the other ankle views because there is 20% evidence of bilateral coalition. So I will check also the other.
Doctor, are you sure this is a bony coalition?
Yeah, I can see
Hello?
that there is bony. Yes, bony projection.
Yeah, yeah. See, there are a gap between the two bones, or the two part of coalition. Okay, so
Yes,
if a
yes,
pony, you must see a complete fusion. So at least
yes.
this is not pony. What is the other type, possible type of coalition?
Yeah, could be cartilaginous or fibrous.
Or five? But okay, thank you. Could you tell me exactly what, what the name of the structure of calcaneus and talus here, which coalesce, which part?
Yeah. I
What
think
is the name
the
of the part?
cystinoculum tali
Okay,
of the calcaneus.
excellent,
Yes,
excellent, and
and the I think one of the tubercles of the talus bone.
okay, middle. Thank you, doctor, so much. You did very well.
Thank you, sir.
Take a home,
Thank you.
home message. Don't exclude. The beginning you told me there are no coalition. No, no. Don't tell an empirical exclusion because this is against you completely. There are a tailor pick, very obvious. At least if you didn't see the C shape, there are a tailor pick. How can we be sure this is a C shape? Look here, look here. This cortex, see, complete. Really, really. Look from here, down. No any point of separation at all. So it is a coalition. Number number three, I think the inclination angle here is not normal for the ankle. Number four, the patient has a chronic pain. Chronic pain. Number five, we ask better for axial in X-ray. Next candidate. Thank you, doctor, so much. Next candidate.
Thank you, sir.
Hello. Welcome. Next candidate.
Yes, sir, I'm here.
Would you ask control, please?
Yes, sir. Uh, Sir, I have requested.
On this
Okay.
patient presented with
Uh,
weight loss, 80-year-old male patient presented with weight loss, abdominal pain, and tension. Go
okay.
on.
So I'm provided with CT scan of patient who presented with abdominal pain and weight loss.
Yes.
I'll take a moment to scroll the entire stack. The obvious
Mhm.
abnormality I can see is SITs. The patient has given oral. Sir, I think it's not scrolling well. Can you scroll for me, please? Okay, I'm provided with images with oral contrast only. I could appreciate diffuse ascites in the abdomen along with mild peritoneal nodularity.
Yes.
The visualize oral contrast is seen opacifying the stomach and uh, passing into the duodenum. Mild thickening of the walls of the stomach is noted. The small bowel loops are clustered in the
Mm-hmm.
right hemiabdominal, mild, significantly
Good.
enlarged lymph nodes.
See, doctor. Where do you think the pathology? First, you told
So
me there
peritoneum.
are you told me a nodular peritoneal thickening
Thickening.
and ascites. Okay, this is very good.
Yes, sir.
Trace this pathology, please. Don't
Sir,
don't
I'm
tell. Mm,
excluding the causes like it could be due to it could be tuberculosis. So I was looking for any enlarged lymph nodes. It could be any due to any
and see.
malignancy. So
Yeah. So when you are working, tell the examiner, doctor, that it could be tuberculosis versus metastatic peritoneal deposit. Like
okay, sir.
this, the examiner will not
Okay,
know what is in your mind if
okay,
you
sir.
didn't talk. So you are
Okay, sir.
excluding any
Yes,
GIT
sir.
primary. Mm,
Yes, sir. Yes, sir. So I could appreciate. I think there's mild thickening involving the stomach pyloric end. Can you show me the other sequences?
no, no, the stomach is
Post.
normal. Look at this
Okay.
post contrast. Stomach is normal. Don't worry about it. See
Okay.
where, where,
Yeah.
where. This is normal by the
Yes,
way.
the stomach. Okay, sir.
What else? What
So
else?
I could think I could appreciate something in the pancreas, the body region. I could
Excellent.
see subtle
What happened?
hypo enhanced. Sorry. I could appreciate a
Excellent.
tiny hyper-enhancing lesion in the body at junction of the body and the tail of pancreas. And I would like to confirm it on the other sequences if available. Otherwise, I'm thinking of pancreatic adenocarcinoma with metastatic spread to the peritoneum.
Excellent.
So, sir, I would like to scroll and see any other possible mets. However, I could not appreciate any mets in the liver and the spleen. And I would like to inform the primary regarding these findings, and
Yes.
would need a biopsy of the
Where,
lesion to confirm it.
where, where will you to refer the patient? To which committee?
Sir, hepatobiliary MDT.
Okay. Okay. Thank you, doctor, so much.
Thank you, sir.
The most tricky point here is that the patient is 80 years old and the pancreatic tissue is almost atrophic. See,
Yes, sir.
but yeah, it's very tricky case. See, uh, the only part is different from other pancreas. This is the normal pancreas. This is the normal. But here, this is looks relatively bulky. Okay, see, the normal pancreas is very thin, and about the body and the tail junction, there are thickening and the hypoenhancement. So it was a case of pancreatic ductal adenocarcinoma complicated by peritoneal carcinomatosis. Really, you did very well, doctor. It was a second next candidate.
Yes, doc.
Uh, Second patient post trauma.
Okay. Can I ask the
Hold, please.
control?
Yes, please.
Okay.
Go on.
Okay. I've been provided with sagittal cuts MRI for the knee joint. Um, it's T1 for immature skeletally patient. After trauma, I can see that there is evidence of effusion. Sir, can I start with sagittal stare or fluid sensitive? rather than this T1. Um, so this I can see that there is evidence of fluid noted within the joint, knee joint. I couldn't see that there is evidence of fracture noted within both distal femur and proximal tibia. At the same time, I can see, I couldn't see, sorry, just 1 second. It's not, okay, this is both in the sky, okay, appearing normal.
Okay.
BCL
Oh,
also,
no, 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 no.
BC,
Come. What happened here?
this is ACL. Just I was going to comment on BCL appearing normal, but ACL appearing abnormal in its fiber. There is discontinuity within the distal femur. Um,
See, 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 see. The ACL is normal. Okay. The femur
BC,
attachment, this one.
oh,
ACL,
okay,
normal. And BCL is normal. But
is
what
normal. Okay.
happened? Yeah, what happened in this slice?
Um, okay. Just I couldn't see. There is effusion extending within this.
Okay.
Uh,
What else?
I can see that I couldn't see that maybe a fracture or avulsion fracture within the tibia because I can see the cartilaginous surface appearing normal.
No.
Okay. Uh, just I want to comment on the menisci, but
What,
yes, in this.
what happened here? What happened here?
Okay. This is the meniscus. This is the anterior horn of the medial meniscus.
Okay.
Just
This is the anterior.
okay.
That this
Okay.
is the medial one.
This is
See, see. It looks normal.
okay.
Right.
Yes.
And see, here also looks
This
normal.
is the lateral appearing normal. Yes. So the effusion extending through the joint. Um, I want to see the ACL.
Don't worry about the ligaments. Don't worry.
Okay.
See, see,
So
look here.
if there is
Look.
a
Would you scroll? What happened?
yes, yes, yes. Just 1 second. There is a patellar dislocation.
And
Just 1 second. I will scroll from the beginning. Okay. There is a lateral patellar dislocation, and I can
yeah,
see that there is also, I want to look for the lateral retiniculum appearing contact and also the medial retiniculum. However, there is the evidence of bone marrow edema noted.
are you sure,
Um,
doctor? Doctor, are you
the
sure? Maybe.
medial retiniculum showing abnormal hyperintense signal. So this
No.
may be a spring.
See, see, see. There are no media curriculum. What
Yes,
happened here?
this one cut a tear
See,
in the medial retiniculum.
yeah. Oh, excellent.
Okay, and
Okay.
there is bone marrow bone marrow edema noted within the yes here. Okay,
Okay.
and also there is discontinuity of the cartilaginous surface of the patella.
Excellent. Okay. Excellent. So, what is this?
Okay,
So, what is this?
this is a piece or bony shape from the patella.
Excellent, Dr. Dua. Amazing. Last finding, if you pick up it, you will be very, very excellent. Why do you think this patella laterally dislocated? Why? What happened in
Uh,
this slide?
Mostly, it will be lateral dislocation of the patella. I think because the alignment of it within the knee. Um,
What
as I
happened for
understand,
the see, see, what happened for the trochlea?
sorry,
What
what
is the
happened to what?
pathology? This is the trochlea. This is the
Yes.
trochlea. This
Huh.
one, this is the trochlea. What happened for the trochlea?
Um,
Some
I
association, some association, something happen in the trochlea result in frequent lateral patellar dislocation.
As it's maybe shallow surface, and so
Excellent,
with the
excellent.
trauma, it will slightly move the, yes.
So what is the pathology here of the trochlea?
Shall,
This trochlear dysplasia.
okay,
Trochlear dysplasia. Okay, okay.
okay,
And there are lateral patellar dislocation and rupture or complete injury of the medial retinectomy. If we do this CT, see this fragment is a bony fragment
yes,
where from the inferior medial part of the patella. This
perfect,
one. 1 second. This is the patella. Where is the medial? This is the lateral.
okay,
Long is lateral. Long is lateral. This
yes.
is the medial. Okay.
But
Because them
why it's look
the,
continuous in the CT?
see. This part is
Okay,
defective.
okay,
Okay. Where it is continuous is the CT. Which part?
yeah,
See, this is the lateral ball. This is the lateral part. This is good.
okay,
See the cortex. Look
yes,
at the medial one. See, you feel here some defect. At least if you tell the examiner this is a case of trauma, this is OCD, osteochondral defect, chip from osteochondral defect, and you describe the whole finding in the MRI, he will be happy. Okay, what is the finding here? Lateral patellar dislocation due to rupture of the medial retractile ligament associated with edema and contusion and possible OCD, osteochondral defect here. Will be very happy. Okay, I think here, see, this trochlea is unhealthy, not normal. It is a shallow and it looks like trochlear dysplasia. Thank you, Dr. Dua, so much. You did very well. Next candidate.
Assalamu
Next
alaikum, sir.
candidate. Salam.
Yes, sir.
Uh,
Sir, can I ask for control?
yes, please. 6-year-old patient presented with severe headache and visual disturbance. Go on.
Okay. Okay.
1 second.
This is the
Okay.
okay, sir. This is MRI T1 sequences of a 60-year-old male who presented with the headache and
Can you
nausea.
scroll?
For the first tracking, yes, sir, I'm scrolling. Let me, sir. Yes, it is scrolling now. Okay, sir. The first tracking abnormality in this MRI that I can see that there is evidence of a hyperintense lobulated heterogeneous lesion noted at third ventricular and suprasellar region with evidence of a hyperintense lesion or hyperintense component also. This is causing splaying of the splaying of and uh, causing mass effect on the midbrain also. This is also causing some mass effect on the optic chiasm. There is also evidence of compression or mass effect on the bilateral internal carotid arteries also. So this is likely a suprasellar lesion with the differential densities. I would like to see it on other sequences as well, such as post-contrast T1 images for further evaluation of the extent of the lesion. Sir, if you
In,
allow.
in correlation to patient age, give me a differential.
Sir, it can be craniopharyngioma. As a patient is there are differential densities. And okay, this is the post contrast sagittal image of the same patient, in which I can see that there is enhancement of peripheral enhancement of the lesion, and it is also causing mass effect on the, as I have previously described, brainstem, and also some mass effect on the optic chiasm as well. There is evidence of solid hyper enhancing components in it also. So it is confirming my diagnosis of craniopharyngioma for this age. Further, I would, and in this particular case, it is not causing significant dilatation of the ventricular chain. So I will see the notes of the patient if there is any previous imaging available, and I will compare the sizes of this lesion, whether it's progressed or regressed, and I will refer the patient to neurosurgical department for further management as it requires surgical management and biopsy correlation.
And doctor, do you know how many types of craniopharyngioma?
Yes, sir. There are two types. First is
Distant,
adenomatous, which is
distant,
having solid components, and the second is cystic, and this is majorly
no,
cystic variety
fro-
with
from
some.
from from pathological point of view,
Okay, sir.
what is the
Um,
mm-mm. What is the different type?
what is the different type? Uh, sir,
Mhm.
I'm not sure. Maybe malignant or something. I'm
No,
not
no,
sure
there are
about it.
there are an adult type and there are an pediatric type. Pathologically, which type is the pediatric one?
Pediatric is, I think, adenomatous.
Excellent. And the adult one?
Cystic or papillary.
Excellent. Thank you, doctor. You did very well. See, my colleagues,
Thank
as I told you before many times, in any brain space occupying lesion, you should ask the examiner for sagittal, especially post contrast. Why? To rule out any tonsillar herniation. Or leave the mouse, doctor, please. In any case, okay? Because most of us under stress forget which tumor cause drop metastasis, which tumor cause like this, like this. So take as a general technique. Ask for sagittal, rule out tonsillar herniation, rule out meningeal, either pachymeningeal or leptomeningeal metastasis, and look at the skull base, the cella and supracella, and the binary region. Very important. The sagittal is very important, especially in space occupying lesions. Okay, and the examiner will be happy. Also, in case of MS, to rule out any upper cord plaques. This is all of this are very critical, and you are showing examiner like this that you are safe radiologist. Okay, next candidate.
Thank you, sir.
Welcome. Next candidate.
Welcome, sir.
Sam, request control, please.
Sir, requested control.
Okay. 6-week female.
Sir, you gave me control.
A 6-week female patient presented with acapnia, subcostal retraction, and systolic murmur. Go on.
Sir, I've been presented with the CTA images of the chest. First, I would like to scroll through the whole of the images in order to see the pathology. Um, uh, um, Sir, I see there is interruption of the aortic arch uh, with the figure of like
Where,
if you can
where,
see after. Sir, at this
where is the
level,
aortic arch?
there
See,
sir
one
this
sec. Where is the aortic arch?
sir this one
No.
So this
Go,
is
go.
the aortic arch.
Leave the mouse.
So
This
this
is the
is the,
aortic arch.
so
Okay.
this one. Yes,
Yeah,
sir.
go.
Yeah, go.
Go
If we
with
go
it.
further, sir,
Trace it.
this one. Sir,
No,
then
this
there
is
is
the
the origin.
normal major facets. Go on.
Yeah, these are the no
Trace.
normal major vessels, and then it
Yeah,
goes
yeah.
further
Go
here,
down.
here, here,
Go down.
here,
Down.
here, sir, sir,
What
here, and
happened?
then it
Down,
becomes,
down, down.
and this
What
is the
happened?
descent.
Normal.
Okay, so there is
So
no
you
inter. So
ex
so this,
you
I
exclude
thought
you are
this
see, see,
part.
you are in the correct pathway. You exclude any aortic abnormality. What else? Is there are any
Okay, sir.
pulmonary artery? See, well, step by step.
Yes, sir.
Is there are any pulmonary artery abnormality?
The first most
Trace.
striking feature is actually this balloon-like dilatation that is seen
Excellent.
in the left apex, and there is like an aneurysmal dilatation of brachiocephalic trunk as well.
Excellent. Why?
Uh,
Why?
because sir, this vessel is abnormal. I'm trying to trace what it is. Sir, it is
Yes,
actually
yes,
the,
yes.
yeah, this
Excellent.
vessel, sir.
Trace it. Trace it.
Yes, sir,
Okay.
it is actually the I think the left brachiocephalic trunk that is draining into the pulmonary artery,
Not
because
pulmonary artery.
sir,
This is
this is
not
pulmonary.
pulmonary artery. This is pulmonary other, يعني other than pulmonary artery. See, this is
This,
the pulmonary
sir,
artery.
this is the pulmonary, yes, sir, and this is the brachiocephalic, most, yes, sir, and it is going. This is the
Draining
pulmonary, yes, sir.
what? Draining something pulmonary also. A brachiocephalic draining for pulmonary structure. Do you know their names?
The pulmonary veins.
Yes, excellent. Yes,
Yes,
excellent,
sir.
excellent.
So yes, sir.
Go,
So,
go,
sir, this is
go.
actually a supracardiac type of, sir, the figure of eight sign, uh, uh,
Excellent,
total anamnesis pulmonary venous return with figure of eight sign, sir, snowman sign.
excellent,
Yes, sir.
excellent. See, see, leave the mouse, leave the mouse,
Yes, sir.
leave. See, my colleague try to believe in yourself. Believe
Yes.
that our doctor start very well, but she came in the middle. She become hesitated. Why? She can't trust herself. No, trust. You are correct. See here, what happened here? She start from the most striking abnormality. What is this? Dilatation of the superior vena cava, and she
Yes.
trace. Oh, doctor, there are dilatation of brachiocephalic. Oh, okay. What else? Oh, doctor, there are some abnormal vascular structure here. So I ask her, please trace it. You are in the correct pathway. When she go. This is the structure, by the way. Okay. She go. This structure is connected to the lung. See, branching in the lung. It is really, it is much obvious in the coronal. See, which structure in the lung has upper and lower, upper and right and left branches. So we are talking about four structure draining by a main vascular structure to leave the mouse to this brachiocephalic and causing brachiocephalic and superior vena cava dilatation. So this is a supracardiac type of total anomalous pulmonary venous return. Thank you, doctor, so much. But you didn't tell me your management.
Yes, sir. Sir, I will refer this patient to inform the finding to the referring physician and ask for the uh, cardiovascular refer to the cardiovascular surgeon for the further workup.
Excellent. Thank you, doctor, so much. You did very well. Take a home message for all of you. In all cases like this, look, this is not a chest. It looks like something cardiac, and the patient is so young, 6 weeks. So think about cardiac or vascular anomaly. Like the doctor did at the first, she was worried about the aortic arch. So trace anything you worried about, trace. See, the aorta is normal. And then I ask her, please exclude or trace the pulmonary. This is the pulmonary. If you trace it, the pulmonary from the origin, this is the origin from the right ventricle. Go up. It is dilated. Okay, no problem, but no major problem. Then the most important and the most common missing structure that most of us miss it, the pulmonary veins. Pulmonary veins. Okay? Total pulmonary. See here, superior, right superior, right inferior, right inferior, right superior. This one. So it was a case of total pulmonary venous return anomaly. Thank you so much, doctor. You did very, very well. Next candidate. The last
Good afternoon,
case
doctor.
was, good afternoon. The last case was total anomalous pulmonary venous return. This patient has a left hip pain.
Okay, this is a I'm presented with a frontal radiograph for a left hip for a patient presented immature patient presented with left hip pain.
Okay.
What I can see that I can see that the epiphysis of the left femoral head appear slightly sclerotic.
Fine.
Uh,
Which part,
and I
which
can't
part of the sclerotic? Which part of the femur is sclerotic?
the epiphysis.
No, the epiphysis is normal. What else?
Uh, okay, I can see that there's uh, there's a cortical thickening seen within the femoral neck.
Excellent. What would you do next?
So I can in my routine practice I would like to check the other orthogonal views.
Orthogonal views shows the same
The
abnormality.
same. Okay, so
Mm.
I would like to check with the CT for this area to rule out. I'm
Or
suspecting this might be osteoid osteoma. So I would like to
doctor,
check in
doctor,
the
doctor,
CT.
before CT, would you like to ask about any history?
Any history?
Yes. Would you like to
Uh,
ask about any history?
I would like to check if there is any previous imaging.
Okay.
Uh,
No previous hemorrhage, no previous images. They
okay,
did an MRI.
okay. So, okay, this is an MRI coronal view for the same patient. Uh, the patient was concerning about the pain was on the left side, so
Mhm.
um, both epiphyses of both femori are normal. Uh, the
Look, doctor. خلاص. We find the pathology in the neck. Don't
yeah,
repeat unrelated normal structure.
okay,
Concentrate in your pathology. See here, concentrate. What happened?
yeah, there is bone marrow edema seen within the left femoral neck
Yes,
with surrounding fluid effusion,
yes.
joint effusion, and edema within the surrounding muscles.
What's your differential?
This may be a stress fracture.
What else?
Uh, what else?
What other causes of this marrow edema in children?
A vascular osteomyelitis infection. If the
Okay,
patient is, but
how
this is
can
not
you
a common sight.
okay, how can you confirm your diagnosis?
I would like to check the T1 if there is hypodensity in this area.
Not you one. How which investigation would you do for this patient?
Um, to check the clinical history and the biochemical profile of the patient if the inflammatory markers are high.
Okay, this is a CT. But
Okay,
really, if you didn't ask the examiner to give you CT, he will not give you. Tell
okay.
me your final diagnosis.
So yeah, so I can see there is a defect here in the cortex in the femoral in the left femoral neck.
Yes.
Yeah, this is suspected for with dense nidus. This is suspected for osteoid osteoma.
Excellent. So this is not a defect. This is a radiolucent nidus with
Radiolucent,
central
yeah,
communication,
yeah.
surrounded by sclerosis. What's your
Mm.
management? Tell me the management.
I will notify the referral doctor and I will ask for advice for the ortho intervention radiologist because they might need ablation, radio
Which
frequency
type of
ablation.
which? Yeah, thank you so much. You did very well, but take some home message. Here I ask you, don't neglect the examiner question, please. This is very horrible. Don't neglect. I ask you which history you wanted to ask about. You didn't answer me. You told me I will ask about any other
What should
old
what
examination.
should I sorry, what should I do for answering
I
your
will tell
question, doctor?
you. Give me my chance. You will answer me.
Okay. Okay.
Okay. So you must tell any history. Tell the examiner I don't know, but don't neglect any. Here there are thickening here. So you must put in your mind some differential diagnosis like osteoid and the next very important in children, osteomyelitis. So I will ask the history of fever, about history of improvement by this is non-steroidal anti-inflammatory. Very important. Okay,
Mm,
this is very classic case, but just the tricky here that I show you the MRI before the CT. All
mm.
the musculoskeletal, my colleagues, you should ask for MRI after X-ray, except when you suspect osteoid osteoma. You should ask for. Thank you so much, doctor. Next candidate.
Thank you, doctor.
Next candidate.
Assalamu alaikum, sir.
Could you ask control, please?
Yes, sir. Sir, I requested.
Okay.
Sir, should I start?
55-year-old female patient complaining with severe abdominal pain. Go on.
Okay, this is the abdominal X-ray frontal projection of a 55 years old female who presented acutely with abdominal pain. In this X-ray, I can appreciate that in the middle of the abdomen and left upper abdominal region, there is paucity of gaseous shadows. Plus, there is a lucency seen overlying the liver, which has some branching appearance and is reaching up to the margin of the liver. There are multiple dilated gut loops, probably likely small bowel loops due to Taenia coli in the right iliac fossa, and some of them are showing level as well. I can appreciate two levels within them. There is another lucency which is seen, and that is more obvious than the bowel lucency. So it could be some sentinel loop or some free air. Next, I would like to confirm the findings on the CT abdomen, as it is an adult and acute in pain, and there is suspicion of pneumobilia, and there is intestinal dilatation.
So what is your next step?
So CT abdomen with contrast.
Could you give me differential diagnosis from this X-ray?
Sir, based on this, it could be due to any recent passage of stone. It could be due to mesenteric ischemia, usually gives portal venous gas, but it is a possibility. Appendicitis with a local phlegmon and local dilatation. It is
Could you
also
ask
a
control?
possibility.
Okay.
Sir,
Control,
again?
please.
Okay.
Could you start?
Okay, it is. Sir, give me a second, please. Okay. So this is the CT abdomen plane study in which I can appreciate multiple air lucencies within the center. They are not reaching up till the periphery. and they are also seen in the gallbladder lumen area. They are extra. I believe that this central part, it could be extra luminal. It is not in the GB lumen and not in the GERD. Mm, um, there are multiple dilated bowel lobes, and there's a density seen with a laminar appearance seen within the ileal. Yes, there are ileal lobes. Another density is seen which is in the adjacent to the bowel and showing some inflammation with the interior abdominal wall. Mm, this is, I believe, on the left side is the gut contrast. There are multiple inflammatory changes with the interior abdominal wall as well. I can appreciate that there is another calcification here. It could be phlebolytic. Sir, I'm trying to look for the
Give
site of obstruction.
give me
This,
give me doctor, give me your differential, please.
okay,
What's your
sir,
diagnosis?
my diagnosis is cholecystoenteric fistula at this place. Sir, can I see it on coronal? And gallstone ileus, but
Excellent. Here's the mouse. Here's the
gallstone
mouse.
ileus,
Doctor, look. Where,
Mhm.
where, 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 where's the first stone?
Sir, there are two stones. One is here, it is causing intestinal obstruction. One is here, it is leading to cholecystoenteric fistula, and that is
Where,
leading to
where, where?
retroperitoneal lobe.
This one. Where is it? This one.
Hmm. Sir, sir, should I go again? It is, sir, these are jejunal lobes or proximal ileal lobes.
Okay. See?
Yeah,
Trace this
yeah,
one.
this is,
Trace, trace. This with me. Trace, trace. This one still here. Here, 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 here. I'm going down. This is the head of pancreas. Okay. Up, 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 up. See? It's connected with the pylori. So, where is it?
sir, it is D3 level.
Okay. So, give me your final diagnosis, please.
Sir, my final diagnosis is this is cholecystoenteric fistula and gallstone ileus, both. I will urgently communicate the findings to the surgical unit on call for laparotomy,
Thank you.
probably.
Thank you, doctor, so much. Dr. Rabia or Dr. Mahwish? Name?
Sir, I'm
Thank
Maria.
uh, Dr. Maria. Thank you, Dr. Maria, so much. Really, you did very well. This is a case, except this is within the duodenum. Okay, so this is a Povert syndrome. This is a type of gallstone ileus, but the stone is within, see, this is the stomach. Trace the pylorus. Where is the pylorus? This is the pylorus. This one. Okay, this one. If you trace this one, this is the first part of duodenum wall. Trace, 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 go down here. This one here. See, there are vertical and transverse. So this is a duodenum. Okay, and you pick up
Mhm.
another one here. Okay,
Okay.
so this is a Bovert syndrome. Thank you, doctor, so much.
Sir,
You did very,
sir, which syndrome?
yes, Bovert syndrome.
Borver. Oh,
Bovert.
thank you so much, sir.
What,
Thank you.
what is a Bovert syndrome? This is
The
when the
gallstone
gallstone, yeah, when the gallstone within, uh, when the gallstone within
gastric
the duodenum,
pylorus.
oh, Bovert syndrome. Okay, and it
Okay,
has
thank
the
you, sir.
right regular triad, pneumopilia, biliary lysiasis, and intestinal obstruction. Thank you, Dr. Maria, so much. Next candidate,
Good afternoon, sir.
Shannon, 60-year female, Okay, 60-year-old female patient complaining of right-sided otalgia and hearing loss. Could you ask the control, please?
No, sir, I'm sorry. I am on phone. I cannot.
Okay.
Okay. I'm provided with axial cuts of CT scan of the skull base, bone window in a 60-year-old patient with the right-sided hearing loss and otorrhea. I can see that there is uh, soft tissue density filling the lumen of the external auditory canal, causing bulging of the tympanic membrane. There is decreased aeration of the mastoid air cells on the
This
right
one?
side as
See,
well.
see. Doctor, you mean this one?
Yes.
No, see, it is similar to the
Wax?
contralateral side. See, it is
It,
nearly similar
hmm.
to the contralateral.
Can
But
it be
there,
wax within the external auditory canal?
at least it is similar. What else? What
Yes.
happened here? See, look at this one. What happened? Compare both
Um,
sides.
yes. Actually, I'm looking at the clivus, this normal, the
No.
petroclival,
See, compare the external
the
auditory or the
externals.
auditory canal
Okay.
here
Yes.
by the contralateral side. Look
External
at the bone,
auditory canal.
please.
Yes, there
Look
is
at
mild.
look at the bone here
Yes,
and
there
here.
is cortical destruction or cortical
It's
breach
on.
involving the posterior wall of the right external auditory canal. There is bone rarefaction and underlying sclerotic changes with opacification of the underlying mastoid air cells. And there
One.
is also an overlying soft tissue density on the right
Oh,
side. So I
oh,
want to. So I'm thinking about an aggressive bone lesion involving
this one.
the right external ear. I want to ask about the history if the patient is diabetic or not, uh, and if no, I will proceed with the MRI of the skull base to correlate and to assess for any possible soft tissue component of this destructive lesion.
1 second. This is MRI.
So this is the corresponding MRI of the patient in T1 weighted sequence, where I can see that there is an irregular soft tissue intensity lesion filling the right external auditory canal and
See,
extending to the
doctor,
right
1 second.
petrous apex.
No. 1 second.
Yes,
See here.
yes.
What
This
is
is the,
inside? See, bilaterally,
yeah,
you mean this one? I will show you. Because the lesion actually is small. Okay.
this is the
You mean
T1 post contrast.
this one or this one? This one or this one?
I mean, yes, this one.
This one? You mean this one?
Yes, I mean this one because it is
Okay.
lateral to the jugular bulb.
Oh, because this one, not the tumor probe. Okay, this is not
Yes,
the tumor. Why? Because
yes,
not enhanced. But see here, there are enhancement here, not seen here.
yes.
Okay,
Within the right
so
petrous bone. So I'm dealing with
okay, not
ab
exactly at the right petrous. It is in the wall of the auditory canal.
So I'm dealing with an aggressive lesion, having a soft tissue component with avid post-contrast enhancement
Yes,
involving the posterior wall of the right external auditory canal, causing bone
yes.
rarefaction in the visualized CT scan. So my
Okay.
differential diagnosis would be first the glomus tumors, second the second differential could be an aggressive bone tumor like an osteosarcoma or chondrosarcoma
Or
or
squamous cell, squamous
sorry,
cell, squamous cell carcinoma. Why not?
squamous cell carcinoma, yes, of the external auditory canal is another
Yes.
possibility with aggressive bony and soft tissue components. And the
Excellent.
patient's age is 60 years old with a long-standing hearing loss and otorhias goes with this possibility. Based on the provisional diagnosis of an aggressive bone primary tumor, further investigation with the biopsy of the lesion is recommended to confirm the diagnosis. Then staging CT scan of the neck, chest, and abdomen is important to look for any possibility of metastatic lymphadenopathy, and then referral of the patient to the appropriate head and neck multidisciplinary team, oncology team for further evaluation and treatment of the patient.
Thank you, Doctor, so much. You did very well. But the way, just after 4 months. So here, the mass is very obvious. But let's start from the CT that I showed to the doctor. Just here you can pick up, no, this is right, here. See, cortical erosion, not here. Okay, my colleagues,
Yes.
don't think this is some abnormality. This is normal tissue. And this one, maybe wax, maybe something else. But the abnormality is here. This one, this is cortical destruction. Okay. Then after that, this is the second MRI. Okay. See? Unfortunately, the contrast is coronal. See? The mass is very small, 1 centimeter by 1, very small. Okay. Then after that, I don't know why the patient didn't remove it. The destruction become extensive.
Yes.
So, see, the
Yes.
destruction and the dehiscence to the jugular canal, everything destruction. So when they did the last MRI 4 months ago, it is very clear. See here, all of this is the mass. I think it is infiltrated the jugular and the sigmoid. Here, see, all of this and
And
the
even
abutting.
touching the internal
Yeah,
carotid.
abutting the internal carotid. It is
Carotid
very
artery.
aggressive.
Yes.
Very aggressive. Thank you, doctor, so much.
Thank you so much, dear doctor.
Welcome. Extended.
Further.
Hello, 65-year-old male patient complaining of sciatica. Would you ask for control, please?
Okay, sir. Okay. Can I? Okay. Okay. So can I hear the? Can you tell the age of the patient?
See.
This is the sagittal reformatted images of the CT scan of an adult patient. There is evidence of decrease in the intervertebral disc space at the L5S1 level, and a vertebral intervertebral spacer, I think, is placed in the L2, L3 level. There is some soft tissue component is seen in the vertebra in the spinal canal, but I'm not sure in this plain CT scan. Contrast enhanced CT scan is needed to delineate it. There is some irregularity of the L5 vertebral body, both the end plate, upper end plate, lower end plate, and anteriorly. The cleft, a small lucence is also seen through the vertebral body, and posterior elements. Posterior. I would like to see the bone window images to see for the destructive lesion, and there is doubtful prevertebral soft tissue also. So I'm suspecting, but intervertebral disc space is not completely lost. So possibilities include osteomyelitis, spondyloarthritis. It can be infective or neoplastic etiology. Can I know the age of the patient, sir? If the patient is an okay, in the bone window, I'm seeing the destructive changes, but there is loss of vertebral intervertebral disc space and end plate changes only, no complete destruction of the vertebral body. There is significant degenerative changes also, suggesting that the patient is an elderly patient. Um,
Yes.
The possibilities of back pain, it can be anyway. I will possibilities include some infective process like pyogenic or
What
tuberculosis,
else? What else?
or a neoplastic process. Neoplastic process in this destructive neoplastic process in this age group in elderly patient include multiple myeloma, metastasis, and lymphoma.
What will you
Uh,
next?
Sir, the patient need an MRI scan for further evaluation to see for the
So,
MRI scan, even weighted images shows hypo. It's a significant hypointensity involving the L5 vertebral body with the prevertebral as well as prevertebral extension of the soft tissue component, as well as into the extension into the spinal canal. Posterior elements are also involved with the uh, there is no evidence of any of the mild extension of this into the S1 vertebral body, is upper aspect of the S1 vertebral body is seen. So in elderly patient, I am suspecting a neoplastic malignant process with the posterior element involvement and spinal canal involvement. This could be a metastatic single lesion also, so it will be most probably a metastatic lesion or a okay. There in contrast on contrast administration, there is evidence of uh, soft tissue component showing enhancement, but there is no obvious evidence of any abscess formation as there is no peripheral enhancement. This could be a metastatic lesion or a lymphoma or myeloma, and because of the extension into the spinal canal, I will inform the findings urgently to the neurosurgical team for a decompression, and the patient needs a biopsy correlation for confirmation of the lesion,
thank you,
confirmation of the
doctor.
diagnosis.
Thank you. You did very, very well. This is a case of L5 lymphoma. She sees the sclerosis here. See here. And this is not bone destruction. This is just erosion. And the most important here that we have a large soft tissue, extraosseous, larger, very larger than in comparison to bone erosion. This is very characteristic of lymphoma. Okay. And when we did the MRI, see, complete infiltration of the L5 and with extraaxial, extraosseous soft tissue extending intraspinal. So this is lymphoma. Anyway, you did very well. It is not important to meticulously or definitely tell this is lymphoma, this is what, this is multiple myeloma. You tell the examiner the possible differential. Thank you so much. To remember how many candidates still remaining?
You can
Next
listen
candidate?
now. After
No?
20.
There are 20 candidates.
Yeah. All finished or still, still
I
some
think we
candidates
all
left?
finished. Last one was 20.
Okay.
Again.
Dr. Amir? Dr. Amir left? Okay.
Last one on the list was 20.
Okay.
Can I
Can I,
All potential
again,
candidates. 1 second. Give the mouse, doctor. All
can I
candidates
take
scheduled. all the candidate in the list take their chances, or still some candidate?
No, all of us took our chance
Okay.
one by one. Yes.
Yeah. Candidate 18 raised hand. Tell me, doctor. Candidate 18. Yes.
Okay. Yes, sir.
You take your chance or not?
Sir, I took my chance.
Okay.
Sir, all the 20
So,
candidates have took their chances in the list.
okay, thank you for all of you for your attendance, especially deep-hearted thanks to Mayor. Really, he are doing a lot of effort. Um, my advice is for all of you. The hot seat is a nervous game. Don't worry, all of you have a good knowledge. Trust in yourself. I remark today, most of you, I think in his mind the correct answer. But many of you didn't trust, oh, this is really, this is the answer. For example, this great doctor for total venous anomaly, pulmonary venous return, she go in the correct pathway and suddenly she stopped because she is not familiar with this case. And this is the scenario of FRCR exam. Typical cases, typical pathology in a typical location like this. Please tell the examiner what is in your mind. Okay, even if it is not correct, he will not demarcate you. He will tell you, no, give me another possibility like this. But many of you retain the correct answer inside their mind. This is not good for you. Tell what is in your mind. Another advice, when you start to describe, don't ask for many sequences before telling the examiner, oh, doctor, it could be like this. So I will ask for diffusion most often. Okay? Be reasonable. Thank you, my colleagues, so much. Happy Eid. Hopefully,
Thank
we
you so
will
much,
meet.
sir. Thank you so much for a wonderful session. Excellent collection of cases. Thank you, sir.
Thank you. After Eid vacation, and I think after 14 May, I will do a continuous week of um, hot seats. I will arrange with Dr. Nahla first for all joint candidate and for all others also. Uh, Before we announce it, I will arrange with Dr. Nahla. Uh, Hopefully, all of you pass. Thank you so much.
Thank you. Happy Eid.